And we continue this journey with the next stop about infection prevention and control. Again, a very important topic. You know, preventing infections everywhere, in hospitals, in the community, on farms. It is our first line of defense. And sometimes when you speak to people and you say, but AMR is also infection prevention and control, they say, what? No, yes, it is. It is. And if you do a very good infection prevention and control, you save antibiotics. Prevention is a universal language, from hand hygiene to animal vaccination, from biocide management with the environment to safe surgery. So it's time to turn to infection prevention and control with our expert teams, and I call first on stage Maria López. Thank you, Maria.
Thank you, Marie-Cécile. Hello, everyone. Good morning. My name is Maria López. I'm from ICO, Spain. And on behalf of the JAMRAI IPC colleagues, I will introduce our session. We are thrilled to go through some of our achievements on infection prevention and control across the three sectors: human, animal, and environmental. To begin with, we will show you a 2-minute video presentation to introduce IPC as the first line of defense to prevent antimicrobial resistance. A big thank you to the communication team who produced this video.
Antimicrobial resistance is a complex threat that demands a unified solution across all health sectors, care settings, and countries. A simple yet powerful first line of defense is infection prevention and control, IPC. Every infection we prevent is one less chance for resistant strains to spread and one more chance to preserve the antibiotics we still have. And once antimicrobial resistance has emerged and become prevalent, IPC, more than any other intervention, becomes critical. When treatment options are limited or failing, stopping transmission is often the only way to protect patients, animals, and communities. Supporting IPC means more than producing guidelines or surveillance data. It means sharing best practices, interconnection within sectors and across sectors, organization and countries, so effective solutions and experiences can be shared. A focus on IPC guidelines, tools, skills, training, and knowledge exchange is at the heart of EU-JAMRAI 2. In human health, it is the hand hygiene that stops an outbreak. It's the safe use of personal protective equipment that protects vulnerable patients. In animal health, it is the biosecurity on farms, its vaccination programs, and responsible waste management that prevents outbreaks and reduces the need for antimicrobials. And in our environment, IPC means safeguarding our water and soil from contamination through effective waste treatment. It's about breaking the cycle of transmission that connects us all. But guidelines, tools, and knowledge are not enough. Behavior change science helps us understand why people do what they do and how to address the practical, social, and cultural barriers that so often block good IPC practice. It turns awareness into action and action into habit. In EU-JAMRAI 2, we are connecting the dots. From paper to practice, from the hospital to the farm, we are strengthening the foundations of One Health and creating solutions many can benefit from.
Our work on, Thank you. Our work on IPC shares common objectives among sectors. Together, we focus on standardization, implementation support, and knowledge exchange to create a structured approach in Europe. And now, we're going to present you some selected results and touch upon next steps. I give the floor now to Anne, my colleague from the animal sector. Thank you very much for your attention.
Good morning, everyone. It's my pleasure to be here and to update you on the progress, the insights, and the road ahead in animal health. More specifically, implementing IPC in the animal health sector. Our work is embedded in this core message. harmonizing, strengthening, and enabling IPC in the animal health sector. And it's not only about the technical guidance, but it's also about creating conditions that make IPC doable in practice. Our task also corresponds to the EU Council recommendation, our favorite document I heard yesterday, and more specifically, this recommendation to encourage the advice and the uptake of biosecurity and IPC measures. Over the past 2 years, we have addressed this through evidence and through dialogue, together with our colleagues working on antimicrobial stewardship in the sector. We conducted surveys on IPC tools and IPC guidelines and literature reviews, and we had a wonderful expert workshop last year in Bilbao. And I'd like to give you a little glimpse of that workshop through the following video. Thank you to the wonderful comms team helping us to translate our ideas into this video. So the workshop highlighted many topics, and many of those we've been continuing to work on, but it also highlighted co-creation as a key principle for IPC implementation. And as you can see in our roadmap, this translates in further engagement, not only the engagement between the partners to build upon the evidence generated, but also engagement with the field, with the veterinarians. And to this end, we have organized veterinary focus groups across different member states. So many of our partners, they went into discussion with the veterinarians in the field. And as you can see, we organized these focus groups across diverse fields. Yeah? The animal health sector is very diverse. And so we had these discussions between veterinarians in the animal health sector, food-producing animals, as well as in the companion animal sector. In addition, FVE organized mixed focus group sessions, bringing together veterinarians from different member states around the table to discuss IPC measures and the implementation of it. So far, 129 veterinarians have provided a broad range of perspectives, and more focus groups are currently being organized. So these focus groups are small, structured group discussions moderated by a common set of questions, and we had 4 specific aims in mind for these discussions: to identify infectious diseases relevant to AMR and the use of antimicrobials, discuss different IPC measures, discuss also their implementation barriers, explore veterinarians' attitudes towards the use of antimicrobials and also different preventative measures, and discuss different types of tools and support already available, but maybe also lacking in the field. And we got a lot of information, and I only have a limited time slot. So I will present for you only selected barrier and enabler insights from 2 completely different sectors: the companion animal sector and the pig farming sector. And although completely different in their organization, as you can imagine, across both sectors, 4 major common barrier themes emerged. And bear with me, so we have in there infrastructure and facilities. So often they limit already the IPC implementation, whether it be the lack of space, the lack of isolation and quarantine areas in a clinic or in a farm. Second, we have these economic constraints that IPC competes with time and affordability, and that can range from increased owner costs to also the high upfront investments required from farmers. Third, we had governance and also feasibility challenges that undermine a consistent IPC. And there it was mostly mentioned the lack of enforcement, not only on the farm or on the veterinary clinic, but also beyond, because IPC doesn't stop at the border of the clinic and the farm. And fourth, we had behavioral factors that strongly limit the IPC effectiveness, ranging from an owner non-compliance to prescribing habits of veterinarians, as well as farmer risk aversion. And you hear already that I mentioned a couple of people here. We have the owner, we have the veterinarian, we have the farmer, and we have many more advisors as well. So they all play a role in implementing IPC. For the sectors, we had some specific elements coming up as well. There are existing guidelines. Some more guidelines are being created. They're not always used effectively. There was the call for more screening of multi-drug resistant bacteria. And we have the loss of IPC, the control on IPC beyond the veterinary clinic in the companion animal sector. In the pig farming sector, food producing animals, we have the huge impact of the market volatility and the prices, of course, in their decisions on preventative measures, as well as how production systems currently are. Some of the current production systems, they just limit or they make it very difficult to implement these preventative measures. But I don't want to bring you a message of doom, because there's a lot of solutions and a lot of enablers that were mentioned by the veterinarians themselves. So what would help to make IPC doable in practice? And I'll present you a lot of information on this slide, but it comes down to this. So let's just start visually. You look at the block there, capacity building and training. So the enablers, they range from strengthening skills and confidence, priority to IPC in the work of the veterinarians, to owner engagement. And owner engagement, empowering owners through targeted communication, they do have a role in IPC. Repeatedly emphasized was also the need for a clear, harmonized, but adaptable guidance in IPC, alongside implementation tools. And these can range from checklists and hygiene plans to digital support. Access to diagnostics remains very important to reduce the use of antimicrobials. And in addition to that, many veterinarians also mentioned the need for some system-level support with an enhanced public-private collaboration and the importance of data sharing, something that was mentioned already by the keynote speaker, importance of data, as well as our colleagues yesterday with the different surveillance systems. Some of these are directly addressed in our work in EU-JAMRAI 2, and particularly the harmonization of the guidance. For the pig farming sector, there were another couple of central themes that we can call IPC enablers. And a central theme there is aligning economic incentives with prevention. Through risk-sharing mechanisms. Prevention also needs to embed it at its source. So from the start, if there's a possibility, involve the veterinarian, involve different advisors in the barn design and in the biosecurity planning of the different stables. Clear and practical IPC guidance was also mentioned, together with a coordinated support and advice. And finally, there is the need to exchange more data, farm-specific data, monitoring data, and also feedback mechanisms that are essential to support not only the veterinarian, but also the farmer to take ownership in IPC. A couple of these elements are, again, directly within the scope of our work with creating IPC guidance and core principles to enhance the IPC implementation in the sector. So taken together, these insights feed into our main output. And our main output here is to create an IPC framework. So having this shared EU-level set of core elements to raise baseline standards in IPC, in the animal health sector, and support consistent implementation. So as shown here, the framework is built by bringing together the evidence, not only from the veterinarians through the focus group discussions, but also from the expert workshops on AMS and IPC measures, as well as the surveys and the literature review. So bringing the evidence together from these different activities, we would like to further develop this framework in terms of a guidance document, and that can serve as a practical tool for different stakeholders to start revising protocols, to start implementing a true IPC program in the sector, and to update national policies and national action plans. So I will close by coming back to this core message. Harmonizing. To harmonize, we developed this IPC framework. Look out for it. It should be ready. by the end of fall this year, so we can start building the framework together with different stakeholders and organize different peer-to-peer activities. To strengthen, we had these focus group discussions with veterinarians. We will have another AMS IPC expert workshop focusing on skills and competencies required, and also broaden our stakeholder network. And to enable, we support the local IPC activities from different partners, and we will have these group discussions, peer-to-peer activities, in which we look for implementation strategies for the IPC framework as well as the AMS framework. So my colleagues will tell you more about that in the next session. Altogether, this continues, moving IPC in the animal health sector from guidance to action and make it a practical and a very effective pillar in AMR prevention. Thank you all. And I think next up is my colleague focusing on IPC in the environment sector.
Hello, everyone. It's colleagues. Let me see. So we will share some of our results from the work group. Luis, you have to look that way. We will share some results of the group working on IPC in the environmental sector. My name is Roosmarijn Luiken. Oh. And this is my colleague Lucena. We're from University of Limoges and from the RIVM. So, as the definition of IPC in the environmental sector was not really existing, at least to our knowledge, we needed a definition to start working in JAMRAI. So, how do we define infection prevention and control in the environmental sector as activities that potentially reduce AMR emissions from human and agri-food activities to the environment? And this is in addition to last year, reduce current levels and further spread of AMR in the environment. And here you can see a few examples that we have envisioned from the start that fall under these activities. And I hope you see some similarities with animal and human IPC. So we have worked on a survey to collect information about these activities. And why did we do that? We wanted to provide a first line of evidence of current treatment methods with potential to reduce AMR emissions. While doing that, we wanted to map country stakeholders responsible for these interventions. And we wanted to identify barriers and enablers for their transferability and implementation across countries, and maybe implementation into national action plans. And here we would like to show you some results of our survey. So we are very happy that we have collected 21 examples of IPC interventions in the environment so far, from 9 different countries and from many waste streams, also waste streams that we have not envisioned at the start. Wastewater, that was the majority of our examples, that was expected. Stormwater, sludge, manure, household waste, medicine waste, plant waste, and other types of interventions that help reduce emissions to the environment. And as you can see, we are dealing here with many different stakeholders. And these are typically all activities that are not belonging to one domain. And these are really interdisciplinary activities. And we must also admit that in our group, not for all these waste streams, we have the expertise. So we need to seek advice from outside our group. So when starting the survey, I'm going to share now a few results. First, those results that we can analyze in an aggregated way. But as you can imagine, most of these interventions are unique, so they need one-on-one interpretation. And at the start, we thought these interventions are probably not aimed at AMR emission. And indeed, when we asked this, the majority wasn't, but also a part was. So that was a surprise to us, but really nice surprise. So if an intervention was not aimed at AMR emissions, or what else was it aimed to reduce, then the most given answers were pathogens and pharmaceuticals. So we also asked, what is the implementation framework of this intervention? And as expected, most of them were on a voluntarily basis, but also a legal obligation. And this is interesting because we asked for interventions that go beyond EU legislation. Of course, we assumed that countries were implementing those interventions. So we asked for interventions on top of these EU legislation. So these legal obligations are national legal obligations, which is very interesting and inspiring. And also we asked about challenges and barriers for the implementation of all these interventions, all the different type of interventions, but also they do share same challenges. And one is lack of resources, which is of course also aligning with a lot of voluntary basis. And also one of them is stakeholder involvement and lack of central coordination. These data need further interpretation and also conversation with the experts on these different waste streams. And now I give the word to my colleague, who will share a bit more positive, the enablers.
Can you hear me? Hello? Can you hear me? Can you hear me now? Yes, okay. So regarding the enablers, so we have identified like the recognition of the need for intervention, which it's related to the fact of increased awareness, the low cost and low maintenance of the solution, which is related also to the sustainability, which is good looking forward, and then past experiences, and then other aspects that we listed in the survey, like political will, media attention, legal basis, and education. And well, regarding the waste treatment, wastewater treatment, there are many interventions in this survey. This is like a summary slide of all this. So regarding the sources, most of the wastewater sources are urban, municipal, and industry wastewater, also hospital wastewater, and industry wastewater other than pharmacy. Regarding the purposes of these treatments is for safe discharge into the environment, but also for enhancing water reuse for agriculture and crop irrigation, and supporting industrial water reuse. And regarding the treatment techniques, we have from one side the level, so we only focused on advanced treatments. So this is, you see here, the tertiary treatment and or the quaternary treatment, which is targeted toward the so-called chemicals of emerging concern, which includes AMR. So this means that most of the interventions we see here are towards chemicals or contaminants of emerging concern. And regarding the processes, so this most of the interventions are biological processes or biological plus chemicals. And then in the other category, we have some more examples that are very interesting. One is from the Netherlands, focused on reducing AMR in aspergillus by applying treatment in flower bulb waste. Then we have an intervention in Sweden, which has been long-standing for several years, on the safe and effective handling of leftover medicine. This is not specifically aimed at AMR, but indirectly helps a little. And then there is a dashboard going on from the EU Partnership on Animal Health and Welfare, where they identify hotspots of manure emission, well, from AMR emission through livestock manure. And all these results are going to be published next week in a milestone report, but a more in-depth analysis is needed, and it will be published towards the end of the JAMRAI. looking forward, we have to choose which are the best practices among the survey, which, by the way, is still open, and encourage you to continue reporting. And many aspects to select these best practices have been discussed across different meetings and workshops. And we have decided so far to include, most importantly, the efficiency of the treatment techniques for AMR removal, the multi-purpose benefit across different stakeholders of these interventions, and the feasibility for adoption across countries. And then outside the scope, we would leave for now the economic costs, the circular economic principles, and the level of maturity. And well, we will include in the scope the technical characteristics of the intervention, the governance aspects, the challenges and enablers, and we need to study how feasible and transferable these best practices are across countries, because it could mean that maybe a country cannot adopt this practice. And we wanted to finish by saying that we have done very good synergy with the team working on the antimicrobial stewardship in the environment. We are together defining core elements and working on definitions that we will be publishing later this year in a scientific publication. This working group have been identifying target audiences to be trained. They have published a very big chunk of work on needs assessment to analyze knowledge, attitudes and practices related to AMR. And they have published also a repository of training methods. So together with our work in identifying stakeholders and mapping the country interventions, we will crystallize all this into training methodologies and audiences to be trained in order to adopt these best practices. So we wanted to finish without saying thank you to all the people involved in the making of this survey and the respondents. Thank you very much.
Yes, thank you. And I would like to ask my colleague Anne. We want to have now a Q&A session. And after that, the next two presentations on IPC will be here for you. We have two activities. One is with the use of Mentimeter. We want to show you some dilemmas we experience in the field of IPC. And after that, we have some time for questions from you. So we know that the Wi-Fi is not that good here. So we were wondering how many people can enter Menti at the moment, because if the majority can, then I think we can use it. For those who cannot, let me see how we can involve you. First of all, it's possible after a dilemma to speak up. If you have something that is important to say regarding this dilemma, then please raise your hand, and that's for everyone, also if you have not responded. And I want to say that these dilemmas are, of course, a bit black and white. We know that the reality is more complex, but we want to sort of provoke thinking about this, and for now, please make a decision. This is not, we're not going to record this, we're not going to hold you responsible for this answer, but we just want to see what is happening in this audience. We have some general IPC dilemmas, and we have some more specific for the animal and the environmental domain. And for this, I'm not sure if we can do the... Can we start the Menti presentation? So the next slide. And then I think you both need... No, I think it's...
Oh, can you change? Can you move forward?
Yeah? Okay. I see the phone.
Okay. rephrase. Okay, so the first question is depth versus breadth of IPC actions. Resources rarely allow full IPC optimization everywhere at once. Should IPC initiatives prioritize deep implementation in selected systems, demonstrable impact, or broad minimal level IPC improvements across systems? Wider coverage. Try refreshing, yeah.
We are more than 7, right?
Yeah. Does someone wants to comment on this response? We have quite a clear answer to this. Someone in the audience? I can't see.
No? Well, we move forward.
Okay.
Next question. Regulation versus motivation. So in both sectors, we struggle with IPC uptake, and so to support IPC implementation, should the emphasis be placed on regulatory requirements and standards, so to have a minimum compliance, or incentive support and co-creation, to have this ownership and work towards sustainability? It's interesting. Can we say both? That's at the core of the dilemmas. You have to choose. But this is also an open floor, so if you'd like to comment,
which one would
please.
you prioritize?
Yeah. Somebody wants to comment on this further?
Can I comment? Because I actually worked in the veterinary and in the environmental domain, and I guess there's also a bit of a difference. I think in the environmental domain, most will be on legal basis. I know that in the veterinary and the animal health domain, of course, we hope to support all farmers and veterinarians to really come up with their own plans. So I think there might also be a domain difference in this answer.
So the next question is in the interface between animal and environment, treatment at source versus downstream. Manure can transmit AMR residues across animal and environmental systems. To reduce risk of manure, we should act at source levels by reducing pathogens and residues load at the animal farm level, or downstream by treating manure before application. Which one should we prioritize?
Any strong opinions about manure treatment?
We have a clear answer.
At source, but then another question would be who is going to do this at source? Huh? Yeah, go ahead, Christine. Yeah.
Do we have a mic?
Do we have a...
Not on. Oh, there it is. Okay. Sorry, I have a very ignorant question, so sorry if this is very stupid, but in Norway, manure is used to apply to fields, and this is environmentally... Yeah, but isn't that environmentally a good thing to do? I mean, is... If it has residues, then not. No. Okay. So I just wonder about the environmental implications as well, because if we're going to start to use artificial fertilizers, what's the environmental impact of this? We can't think, just AMR. We have to think broader than, don't we? Or maybe I'm wrong. Sorry, I'm completely ignorant. Sorry, but yeah.
As we have seen, many of the interventions described in the survey are not specifically for AMR, but will tackle still AMR.
I think manure application has many purposes, and also with good purposes, sometimes to enhance the ground needed, could have bad side effects. So I think that's what we're thinking about here. So if you use manure, then there could be these side effects, and that could be the spread of residues, for example, or other pollutants. Does that answer a bit your question?
Well, I just hope we consider the environment too.
We have another question.
Yeah.
I've got a microphone. Hi. Hi, again, please. Yes, I thought we were waiting for the microphones. Maybe to answer your question as well, it's not rather the decision whether we want to use manure or artificial fertilizers, but how to treat manure such that we can use it responsibly. So it's not that's not the way out. Yeah.
Okay, hi. I'm Lida from NPH Greece. Concerning the dilemma, my question is the how much, the practicality. I mean, how much would it cost to treat it at source, and how much would it cost to treat it downstream? Would we need new facilities? This is the practical issue that I think that politicians always are going to ask in order to decide. So would it be cheaper and more efficient to treat it at source and let us decide later on who is going to do it than to decide to do it downstream and need to create infrastructures from scratch?
Yeah, thank you for your comment. I think it's a very valuable one in many of the IPC decisions to take that into account.
We have 2 more minutes. So
yeah, let's move on to another dilemma. Yeah? Okay. Another one? Yeah, theory versus practice. So veterinarians prefer concise, practical tools, but policy and guidelines, they often emphasize also the details. Should IPC guidance prioritize the detailed, comprehensive guidelines or the simple, actionable tools for daily use? Perfect. Tool development. I think I'd like to make a comment on this as well. So simple, actionable tools, definitely yes, but assure they are embedded in evidence and in science, and as such that the users of the tools can find their way to the broader picture and the details as well.
last dilemma?
Yeah. So this is about the environment, definitions. The term IPC, infection prevention and control, is typical for human health and should be adapted with another wording for the environmental sector. So I agree, another more appropriate wording is needed for the environment, or I do not agree, it is useful to also use the term IPC. And I think in the animal health workshop, you agree that to use the IPC term instead of biosecurity, right?
We had a whole morning discussion on what is veterinary IPC, because I think we all agree that we cannot just copy-paste from the human sector. So I think it's a challenge both sectors face.
Does anybody want to have a last comment on this dilemma before we go on to the Q&A? Oh, no Q&A. Okay. So this is your chance to speak up or ask a question. Does anybody want to say something about this dilemma or ask one last question?
Hi, yeah, I would like to ask a question. What would be, because infection prevention control doesn't really seem to fit that easily with the environmental sector, but I can understand why you would want to use it to fit in with the One Health approach. But what would be an alternative that would fit more nicely in the environment sector?
I have no alternatives ready, to be honest. For now, what we see is that it's a working area within JAMRAI, where, as you saw, we collect many activities that are not new. Those are existing activities, and they now come together in this work around IPC. And we are currently discussing with the stewardship colleagues, should we indeed have this common definition or change it. But so no, I'm not sorry, I have not yet an alternative, but we're thinking about it. Do you? Yeah. Do you already thinking about something?
No, but I mean, it just strikes me that I'm wondering what gets infected. And so it gives me a lot of questions. I'm not an expert in the area. And I also think from a communications perspective, to reach the relevant target audiences, maybe you need to have a terminology that they can relate to, that makes sense for them. So I think it's a really important discussion.
Yeah, and that's a very good point you raise here, is that it also maybe depends on the audience you're talking to. So it might help a medical doctor if we say, okay, these are the similarities with IPC, reducing spread, for example. But if we talk to the waste managers, it might be very confusing to talk about this and use other wording. So that's a very good point, yes. We have to, it's Ricardo, but we have to move on. Yeah.
No, to expand a little bit more on that last part, because I think that the environment plays a role in the infection prevention and control of humans and animals, in the sense that, sorry? Short?
Yeah.
Okay, yeah, in the sense that consuming raw vegetables, drinking contaminated waters, or bathing in contaminated waters is infection in humans, or putting animals in contaminated grasslands that have been manured too early and without any precaution. It's direct IPC for humans and animals, and then we can also expand from that point to try to reduce emission sources. Sorry.
Yeah, thank you for that last comment. Thank you all for your contributions.
Thank you.
We have here time to close, like in our eyes. Okay, thank you very much.
Thank you.
So, if we could get back to the slides. Oh. Yes, so we're going to start the IPC in human activities, and because we have so many different tasks and activities going on, it's going to be quite quick overview. So one of the things we've been doing is an evaluation report on the IPC core competency technical document from ECDC, which we released at the end of December last year. And the goal with that assessment was to see whether the existing European framework kind of fits the needs of today, because that document was from 2013. So what we've done is gather feedback and opinions from partners that are part of EU-JAMRAI. As you can see, like, we have 31 institutions from 22 countries who's answered that questionnaire, and also an advisory board with IPC experts. And so we don't have time to go over the key results today, but I would highly recommend anyone reads our report. We have recommendations on what to do and changes. But one of the important things we learned as well, the framework has stood the test of time. There's a chance. Oh, that went quite loud. there's a challenge to translate it into everyday practice at local levels. So what we've thought about, what's next? And what we've done to bridge this gap is we've been working on a self-assessment tool that could be a companion tool to this kind of technical documents that could help IPC professionals and leadership take it into practice. And the idea with our tool is to help organizations and individuals assess the existing skills, identify gaps, and priority competency development in more of a systematic way. We have designed this tool to be flexible and scalable, so it can be adapted to different healthcare settings and national context. The idea isn't it's a one-size-fits-all tool. It needs to be adapted to the country setting. And this tool will come out in a few months or so on the JAMRAI website. And this is kind of our solution, our ideas of how to fix this challenge that is from going from like technical, very evidence-based documents to how to implement them into real-life practice. So we were planning on doing a Mentimeter. We've just decided to kind of skip it. So, so we will just move on. So my colleague Asja will come on stage now.
Okay, hello everybody. My name is Asja Kunøe and I'm from SSI Denmark, and I'm going to present very briefly the content of our peer-to-peer program so far. In our tasks within IPC Human Health, we have a great focus on peer-to-peer exchange and exchange of best practices and getting into contact and dialogue with IPC European experts. So now just try to find the presentation. Okay, so we are developing the peer-to-peer program in human IPC health with the UKIC, the European Committee on Infection Control, being a part of ESCMID. And our target groups are not only JAMRAI partners, but all IPC professionals and IPC frontline personnel in the European region. So we believe that need-based support will have the greatest impact, and before getting started with our peer-to-peer program, we carried out a needs assessment survey and tried to base our different activities within the program based on this survey. So by now we have rolled out a number of actions. During 2025, we have started a series of webinars on specific topics, and the recordings of all these webinars so far are to be found at the UKIC YouTube channel. And to get to know our partners, which we have 60 of in our work package, we early 25 we started to carry out one-to-one meetings with all of them to get to know their plans for what they would like to implement, and how this their project is connected to the national action plans, and also what are their specific needs to carry out their project. And we are almost finished carrying out all the one-to-one meetings, but we'll start the second round in February, March this year. Also, within UKIC website, they have started the IPC Nurses Corner for interactive exchange and takeaways for action. And we are also piloting a Q&A hub within the teams, but we plan to work on a more interactive and sustainable solution. So other activities is that we are collecting European peer-to-peer local events. So if you know about one event which is accessible to other people, you can click on the QR code, maybe not now, but it's also to be found in the JAMRAI webpage, and add your event to the list, and the overview will be displayed at the UKIC website. So one more great offer we have is that every frontline IPC personnel can apply for an individual online meeting with an IPC expert. So this is for free, So it only takes you to scan the code and fill in the form, and the expert's actually waiting to get in contact whoever needs this advice. The offer is in particular directed to more isolated professionals who may not be able to interact locally with an IPC professional. So please help us to spread this information in your national and local IPC societies and networks. So what is coming next? We are now going to focus more on peer-to-peer activities linking AMS and IPC with our AMS colleagues within the JAMRAI project. We are starting up in the beginning of February virtual roundtables with direct exchange between peers and experts in a number of different topics. And we are also going to plan for focus groups on specific topics and observerships. So the overview of all our activities is to be found on the JAMRAI 2 webpage, UKIC Education Activities webpage, and we are looking forward to seeing many more of you in our continued peer-to-peer activities. But if you want to know more, please come and talk to us in the information corner during the breaks today. Actually, I think that was it. Let me see. Yes, so next.
Hi again, and now we will be moving on to the efforts made regarding building the evidence base for harmonized EU IPC practices. First, I would like to thank the ECDC colleagues who guided us and helped us through these tasks. First, we undertook a systematic review on diagnostic stewardship in blood cultures. The objective of this systematic review was to gather the most up-to-date evidence-based recommendations on blood culture practices. Among 2,440 records we screened, 17 guidelines, consensus documents, and systematic review were finally included and analyzed. Our ultimate goal with this review was to ensure consistent, harmonized, and high-quality diagnostic practices across Europe, improving patient safety and enhancing the containment of AMR. And what were the key findings? The testing of the blood cultures should be reserved only for patients with clinical suspicions of sepsis and bacteremia and discouraged for low-yield scenarios. The blood volume has to be from 20 to 30 milliliters of blood per set and have to be extracted before antibiotic administration when feasible. For most cases, a single venipuncture provides equivalent diagnostic value and lower contamination risk than multiple venipunctures. And for skin antisepsis, the use of 2% chlorhexidine in 70% alcohol remains the gold standard. A blood culture contamination rate of 1% is a critical and achievable quality measure according to the CDC when good practices are followed. This reduces false positives, antibiotic treatment, and costs. And also, while rapid molecular assays are valuable after a blood culture is positive, they cannot replace conventional blood cultures as the gold standard. And moving on, we also conducted a dual-track benchmarking of European IPC practices. First, we undertook a comprehensive review and updated of the ECDC directory with national and international guidelines. We are very happy to announce that the 30 JAMRAI countries contributed with their national IPC guidelines. And this results and ensures a clear overview of the existing guidance landscape to ensure that the new EU guidelines are built on a complete understanding of current European practices. These guidelines we found have already been sent to the ECDC, so they will update it in their webpage. And also, in parallel, we focused on benchmarking healthcare-associated infection surveillance data. And this work was driven by a clear European priority, that is to harmonize the definitions in line with the ECDC standards, enabling a better interpretation of surveillance data. To that end, we mapped European surveillance systems that collected healthcare-associated infection data and distributed a questionnaire to assess the adoption of ECDC's case definitions. The result of this analysis is a clear overview of the current harmonization level of healthcare-associated infection reporting, pinpointing areas for alignment to enable cross-border benchmarking and for a faster and better outbreak detection across member states. Also, making sure that country-specific contexts are well understood when taking a look at EU-wide data. And we also had a Menti ready, but we are cutting off as well, because we have to give you more time to have a Q&A to ask us about our task, our achievements, or even next steps. So I will be leaving the floor to Fortunato d'Ancona from Instituto Superiore di Sanità, who is not actually here, but is joining online. So I hope everything is ready up there. But I leave the floor to him virtually.
Thank you. Thank you, Maria. I'm very sorry to not be there. I will speak about the IPC implementation, especially in support transforming policy and tools in practice. So we have 3 areas. Digitalization is one of the new pillars of action to combat AMR and improve infection prevention and control. Sorry, I will share my slide because I think that I have to do, looking at the screen. Yes. So the availability of data is very crucial for action monitoring and changing strategies. Furthermore, it's also important to share experience from pilot projects to strengthen good practice and inspire other partners to implement similar activities in different geographical contexts. Then we also have a new, we are creating a new platform Insight, designed by Istituto Superiore di Sanità in Italy, that is one of these pilot projects that we intend to use to provide to all the partners with wider support in the area of governance of IPC. And now more details about what I said. So our result for a week for a digital tool, we conducted a survey and collect information from 16 countries, and they sent a structured description that fits in a repository that is available on EU-JAMRAI cloud team. You can find the folder using the QR code in the slide, maybe later. But our aim is to make it available on public EU-JAMRAI website very soon. This repository provides practical, ready-to-use resource for national and facility IPC programs. With the same objective of contributing to this dissemination of good practice, the Italian National Institute of Health collected also information from participating countries on which pilot project they are implementing in their context, and whether they are using a specific tool for IPC intervention. We are monitoring 19 projects in our repository. Again, you can see the QR code, and later in the next weeks, we will make this information available on the public EU-JAMRAI website. We will keep updated this repository until the end of the EU-JAMRAI project. Finally, a brief description of the digital tool Insight that we are developing. This is for all the partners and institutions that wants to use. Probably it will be ready by 2027. Based on the standard WHO IPCAF, that is a framework that is used to assess how well infection prevention and control programs are implemented in the healthcare facilities, we want to facilitate the activity of analysis and the use of IPCAF, aggregating questionnaires of different facilities. So it is a tool for manager that overview more facilities. The first working demo will be presented in the next workshop in Rome, that it will be held in March, and the system, as I said, will be available to all the EU-JAMRAI partners in 2027. So you can see a sort of continuous implementation cycle. We have tools, we have implementation of tools and pilots, and Insight is one of these. So we are trying to push changes using new instrument. I would like to say thank you very much to all the partners that are collaborating in to the area of IPC. And now I have to leave the stage to Michael Borg and Viivi Eskelinen for another important area, that is behavioral change.
Whoa. Okay, good morning, everyone. I know we are keeping you from your coffee, so we will try to be as quick as we can, but we really wanted to go through the process that we are using in JAMRAI 7.4, in other words, behavior change in IPC. Now, why do, oops, okay, let's wait. So why do we need behavior change in IPC? Well, simply because most of the healthcare-associated infections in our healthcare institutions, especially those caused by antimicrobial-resistant organisms, happen because of inappropriate patient care practices. And if we want to improve IPC, that is what we have to address. We have to address those behaviors, and to do so, we need to learn from behavior science, because, to be honest, we're not that good at that. And arguably, at the moment, the most widely used model for behavior change is the COM-B model, which looks at behavior as the result of three key components: capability, in other words, the ability of a person to do that behavior, whether it is the physical strength and stamina or else the knowledge and skills; the opportunity, in other words, the system, does the system provide physical sustenance of that behavior through time, resources, and tools; and critically, the social opportunity, in other words, the organizational culture and social norms; and then finally, is the individual motivated to do the behavior through both reflection as well as habits and emotions. And the first step that we went through, in line with the COM-B sequence, is to identify the target behavior. And each of our 13 partners, as you can see, throughout Europe, north to south, east to west, have identified a behavior that they are addressing. And in COM-B, behaviors have a very strict definition. Not surprising, with IPC, the majority of those behaviors relate to hand hygiene, specifically moment one, in other words, application of alcohol hand rub before patient contact. That's a behavior. But others are looking at other things, such as appropriate glove use, preventative care for patients, perioperative prophylaxis, management of invasive devices such as urinary catheters, and active identification and detection of MDRO carriers coming into hospital. And then once you have established your target behavior, the next step in COM-B is to understand that behavior. In other words, look, as we have heard in other presentations, for the enablers and especially the barriers. And this is what we have supported the partners in. So together with our colleagues at the Finnish Institute of Public Health, we have developed a flexible tool, a template based on the theoretical domains framework that then the partners could adapt for their own specific behavior. And through this template, they could then identify priority behaviors and group them into those 6 COM-B domains that I mentioned already. And because it was a common template, we could then look across the countries and see whether there were any overarching barriers in each of these domains. And we've had some interesting results. So in terms of psychological capability, this was not the major barrier. Indeed, most of the respondents said that they knew how to do the respective behavior, that they had guidelines to do it, and they had received some level of training. Of course, there's always room for improvement, but it's mainly in refining and applying rather than starting from zero. On the other hand, opportunity was a massive issue. Across the spectrum of all the partners from Europe, time and workload stood out immensely, with respondents saying over and over again, it is a big issue because of our workload, because of competing tasks, and lack of staff. In addition, the environmental setup, the physical opportunity, is not exactly conducive with infection prevention and control, very often with suboptimal placement and reliability of resources, lack of easy access to guidance, and critically, lack of built-in prompts to allow IPC to be done on a day-to-day basis. So basically, it's a question of system dysfunction, which then makes correct IPC practices difficult to achieve. And the other aspect of opportunity is, of course, the social opportunity. And here, there are almost bigger barriers, where, again, across the board, the feedback was, listen, where we work, for all the nice words, AMR is not a real priority. It is not embedded in the organizational culture, and other clinical processes and outcomes are seen as more important. And when we look at our leadership, yes, they talk a nice talk, but very often rarely walk the talk. So there's lack of emphasis by managers, nice commitments rarely translated into genuine support, and as a result, social factors normalize unsafe and non-compliant IPC behavior. And then finally, in terms of motivation, again, the motivation is often there. Staff, respondents agreed that IPC is important for patient safety, it should be done, and it was their responsibility to do it. But, and that's the big but, adherence is often perceived as unrealistic because of those opportunity issues that I mentioned in relation to workload and organizational conditions. And in terms of automatic motivation, this is weak because IPC behavior as a result of all these barriers is not ingrained or habitual, and therefore that's what suffers first. So when staff are tired or overloaded, the first thing to go out of the window is correct IPC. So this is where we have got to. Now our next step over the next 18 months is to actually identify the interventions at each of these partners and implement them to see if we can get an improvement on that behavior. And with this, I will move to Vicky and ask her to continue this presentation.
Yes. So we will be brave and try the Menti now. So I will put the next slide, and please get the QR code, and I will then, ask you the question, and I hope you've been listening to Michael very carefully here now. The identified IPC barriers would be effectively addressed if staff had better training, clearer guidelines, and more surveillance, audit, data feedback. Strongly agree, agree, no opinion, disagree, or strongly disagree. You get some time to think.
And hopefully see the Menti.
More question, do you have a Menti code?
Yeah, there is. Would you like to go back?
Okay, let's do it and get back to the past. And I will ask you guys now.
Forget the Menti.
To maybe forget the Menti. Or wait for the results of the Menti. And we'll see if you're brave in the audience to raise your hand when we look at the question, the identified IPC barriers would be effectively addressed if staff had better training, clearer guidelines, and more surveillance or audit data feedback. Do you agree? Please raise your hands if you agree, strongly or moderately strongly.
There's not one single hand.
Some
Well, there are two hands at the back.
I see.
3, 4, 5. See? So this is agree, okay? So if you think that those barriers we showed can be addressed by improved surveillance, education, and feedback, raise your hand. No, but I have to see the hand. All right, okay, all right.
And now we move to disagree, or strongly disagree. Be brave.
Okay.
There will be no consequences.
It's definitely a majority.
Yeah. Okay, because I can't also see you from here, so.
Let's move on.
Yeah, what we can see, or what I could see, was about half and half, maybe. And if we could now get back to the presentation, please, so we can talk about why actually the disagree group, in our opinion, was correct. So actually, more guidelines, education, and surveillance are unlikely to make a major difference. And that is because staff in most countries, as Michael just mentioned, have high levels of knowledge and positive attitudes, yet the behaviors remain inconsistent. The most identified COMBI barriers that we had were really much about time, workflow, norms, and habits. And as Michael mentioned before, so many of the staff around Europe mentioned the high level of workload and stress, and also hierarchical differences within their units, for example, between doctors and nurses. So if we move on to an intervention that targets education, that can actually have more negative consequences for the behavior, because if the staff report the barriers to be more about time and workflow related aspects, it can cause frustration, blame, and maybe a bit of feedback fatigue. So if we get a concrete example from hand hygiene, which is one of the most popular behaviors across our countries, the environment and workflow do not reliably prompt or facilitate hand hygiene. And as Michael mentioned, hand hygiene is genuinely not supported by culture or leadership or deemed to be essential. So walk the walk and talk the talk. Hand hygiene is often framed as more of a self-protection rather than maybe patient safety, or because of a management says so, and seen as difficult to apply under real-life conditions. And it is not an ingrained habit, and it is easily forgotten when under a lot of work pressure. We were going to have a poll, but we're not going to do that now, so I'm going to just move on to talk about the different interventions we could use for a hand hygiene intervention. So the evidence suggests that the best way to target hand hygiene is actually mandatory personal sensors. It's about real-time, in-the-moment prompting, monitoring, showing the biggest gains overall in the quantitative synthesis. But of course, there are some differences depending on the device design. Second best option is hospital hand hygiene targets plus accountability for persistent poor compliance, which targets social opportunities. And third is more accessible alcohol-based hand rub dispensers, targeting physical opportunity. And only fourth is a workshop on the World Health Organization's 5 moments and a correct technique, targeting psychological capability, coming back to education alone not being enough when we actually want to change behavior. And last would be ward posters on hand hygiene about safe patient care, because as we know, we are usually not very attentive to these kind of posters around us. So in the next phase, it looks very much like when we start looking at the interventions, we really need to look into targeting opportunities, especially social opportunities, and automatic motivation through environmental restructuring, modeling, and enablement, for example, better workflows. And now I leave it to Michael to wrap this all up.
Thank you, Viivi. So just to conclude, so basically, we weren't all that surprised, but because we speak to so many people in these types of meetings, but I think this shows that the issues are pretty much across the board, and the issues are, as we've already mentioned, very often related to opportunities, especially the challenges in relation to time, in relation to work pressures, in relation to dysfunctional systems. At least from a positive perspective, we've seen and we have identified that psychological capability, knowledge, skills, as well as reflective motivation are not major impediments, but of course, they have this background of the opportunity issues. So indeed, most staff know what to do. They believe IPC is important, but they have these challenges. So as Viivi mentioned, just focusing on education and surveillance alone, we're not saying that these are not needed, but on their own, they are unlikely to make an effect because the main problems lie in automatic motivation and social opportunity, in habit formation and organizational culture. And as a result of this, we need to have a multimodal behavior intervention whenever we are doing IPC. And as Viivi said, what we'll be focusing on over the next 18 months will be especially environmental restructuring, enablement, modeling, and incentives and accountability. And with that, I would like to thank all the partners who are working with us in 7.4, and thank you on behalf of Viivi as well for your attention. Thank you very much.
Thank you.
Now we will be having a very brief Q&A because we passed the time. But please share with us your comments, your suggestions. And there's a question there. Diamantis? I don't know.
Thank you so much.
I do have it. Sorry, Diamantis. I do have the micro. Thank you very much for your interesting presentation. I would like to discuss a topic because I was surprised in one of your presentations where you identified the needs, the priority needs for IPC teams. In that survey, one of the 5 topics I identified was antibiotic prophylaxis. And actually, we all agree that collaboration between IPC and AMS teams is key. But I think it might also, like for antibiotic prophylaxis topic, it's a key priority for AMS teams, which deserve specific profiles. And in some countries, the development and implementation of AMS programs and AMS teams might be really challenging. While I think in the development of IPC teams, it's already a way forward. So I was wondering if you discussed this overlap and on a structural point of view, if you have any discussion on that topic.
No, it's like general. Then I can maybe go in. And we are encouraged by the coordination team and for the JAMRAI to close collaborate with our team in AMS that we'll be presenting right now. But we haven't focused on what you suggested. We are actually working currently in our separated tasks. But actually, for the next 2 years, my team from the 7.1.2 will start working with AMS in a set of indicators for a structure and framework, and maybe we can next year answer your question. And sorry. And we just have time for one more question. I think Diamantis was first.
Yeah, it works now. Thank you so much. So first of all, thank you for all the very nice collaboration. Yes. Now, these past 2 years, I think it has been very fruitful. And I have two very quick questions. So the first one, whether the self-assessment tool will include the competencies. And the second question is whether UKIC would be happy to carry on with hosting this peer-to-peer work. Thank you.
Yes, about the SAS question you are asking, the very brief answer is, I think I can say yes. I'm just looking at my colleague Anne. Yeah, it will include some of the results from our evaluation report. Yes, it will. And your second question was about
whether UKIC will carry on with
the peer-to-peer program. Actually, we have not discussed in detail, but most of all our peer-to-peer activities will also be found at the UKIC webpage. So we plan to make it sustainable that our activities will continue in some version at the UKIC webpage, within UKIC after the JAMRAI project. But of course, we need to discuss more with UKIC before I can just say that we'll do it all. And there, just one comment to the question before about the AMS collaborations, that we will also focus on the AMS IPC cooperation for the peer-to-peer activities. That's what's coming next. So we are aware of the issues there.
Thank you very much. I'm afraid we have no time left for more questions, but please approach to us if you have any further comment. And also take in consideration, we will have an interactive corner today, I think.
We have actually, in both coffee breaks, we have an information corner where you can come and ask questions about the peer-to-peer program or just any IPC question you might have. Thank you.
I had some closing remarks, but I can leave.
Oh, I'm sorry.
Okay, no problem.
Bon, can you hear me? Yes. Here we are. So this is the networking break. I'm sorry it will be shorter than previously scheduled as we are already 6 minutes late. So just to let you know that there is coffee at this level just out of the side. But also if you want to do sports very quickly because we have to be back at 11:25, there is also coffee upstairs when you had lunch and cocktail yesterday. And you can visit behind me the info corners, IPC mentorships and pilots, surveillance and country engagement. So please be back at 11:25. Thank you very much.